Hello and welcome back to my channel. My name's Dr. James Gill and you've joined me in a jungle. Currently I'm off doing expedition medicine and I was hoping that I would have had a few more of these videos to do. And given the noises overhead, I'm hoping I survived to the end of this video. I've got bugs and everything at me. This is just before we start. I'm trying to do this little video on expedition medicine and with traveller's diarrhea, and the background's all a bit blurred, but I just want you to see that literally this is me trying to do this thing in the middle of the jungle. I tried to do it down by the beach, but it's far too noisy, and as it stands I've got a creaking tree and I've got birds up there, but at least I can stand in this area without getting completely eaten alive by some of the bugs here. So with that in mind, let's try and start recording and we'll see whether or not you can actually hear any of it over the birds and the trees and the leaves and the wind. Right, I'll see you in a minute. And I was hoping to do several of these videos about what I've encountered on my tropical travels, as it were. And one of the big things that comes up time and time again is traveller's diarrhea. And actually, given the number of patients I thought I've been seeing with it, it would be a very good video to do because it's something that a lot of people get affected by and is quite worrying for many people. And there are degrees where the patient is concerned versus where I'm concerned. And I thought, let's see if we can go through those to help those of you who might be travelling to far off parts of the world, but also for those of you who have an interest in expedition medicine and those of you who may end up treating patients with traveller's diarrhea even when they come back. So traveller's diarrhea is an excellent place to start from when it comes to expedition medicine, because you're going to see people out on expeditions, on trips and things, but also back in the UK when people have returned from them. So I think it's worthwhile that we highlight some of the numbers here. Diarrhea generally is incredibly common. There's at least 1 billion, with a B, 1 billion people a year, not travellers, but just generally affected by diarrhea, highlighting how important this is as a clinical symptom. So we need to have a good idea of what processes to go through when anybody comes in with diarrhea. And whilst obviously diarrhea is a global problem, when it comes to travelling and expedition medicine, it's also very common. Up to about 1/3 of medical consultations will be for the squits, the trots, loose bowels, whatever colloquialisms you want to be using. It's probably the commonest thing that we deal with, and certainly on the expedition that I'm on at the moment, that's definitely been the case. So when it comes to diarrhea, we actually need to know what it is that we're dealing with, and with that in mind there's two very important definitions. First off, what is diarrhea? So diarrhea is 4 or more loose stools in a day. So just having that one loose stool yesterday after dinner isn't too worrying. However, in your 24-hour period, if you've racked up the 4, it's something that you might want to pay attention to. Now, at the other end of the scale, we have something called dysentery, and that's diarrhea, so 4 or more loose stools a day, and associated with blood in the stool. Diarrhea isn't vastly concerning at the beginning. Dysentery, I always, as a medic, want to know that this is going on, and I want people to talk to me as soon as possible. So with that in mind, how can I differentiate someone who's got a bit of an upset stomach, just straightforward diarrhea, from something much more serious? Well, as I've highlighted, blood in the stool is one way of going about it, but I think it's worthwhile that we have some straightforward information that we give to anybody that we're working with, not from a medical background, to know when to give us a call. If you've got a temperature over 40 degrees Celsius, that's major league. I need to know about that like yesterday. If you've had your diarrhea with blood in it, that's bad. I need to know about that. If you're having difficulty keeping fluids down, not terrible in itself, but can become problematic, so again I want to know about that. Whilst I'm not too bothered about the actual number here, if you've just had a temperature, if you've had a fever that's lasted more than 48 hours, that's very important. And if your diarrhea has lasted more than 4 days, again, that's important because I need to think about how do I treat, how do I replace what you've lost. Now, in reality, most people are going to speak to the medic pretty much straight away as soon as they've got that runny bum. So from there I need to work out, again, how do I determine the level of severity, given that you've probably had less than a day when you come and have a chat to me? Well, I have a diarrhea sieve. No, not a funny thing that I'm going to put a stool through. I'll leave that to the lab guys. This is just how I determine where I'm going and how important your diarrhea is medically. It's obviously incredibly important to yourself, and and can have a huge impact on a trip, but it's how much worry do I have to put to it. So in terms of my diarrhea sieve, it's relatively straightforward. What's the duration of the diarrhea? Have they had any blood in the diarrhea? Have they had a fever with the diarrhea? Have they had any abdominal pain with the diarrhea? Is there any vomiting with the diarrhea? And crucially, do they have any ideas as to what might have triggered it? Because that in itself can be really useful. So let's dig into all of those so we understand what I'm looking at. So in terms of the duration, this is going to be hugely important, both for the diagnosis and the management of the issue. I mean, if we're talking about day 1 symptoms, that doesn't really give me a lot to go on. And honestly, we'd expect most diarrhea to settle on its own, assuming there's no red flags, without any intervention from ourselves. And with that, any diarrhea that's under 3 weeks in duration is likely to be infective. Conversely, anything that's over 3 weeks in duration needs to be looked at in a hospital realistically and needs some additional tests very soon. We need to think beyond the viral and the bacterial to think about parasites and protozoas, things like Giardia, things like that, which can give months-long diarrhea if not treated appropriately. And even when it has been treated correctly, the body can still be affected for months afterwards. But any diarrhea over 3 weeks needs to be investigated because it could be that something else has come to the fore. Even if a patient did have infective diarrhea, it may be that that's unearthed a quiescent or an undiagnosed inflammatory bowel disease, or perhaps rarely even generated an inflammatory bowel disease as a result of the diarrhea. Slightly less concerning, we can still have traveller's diarrhea causing irritable bowel syndrome, but both of those I want a specialist to have a look at the patient, do bloods and potentially organise a colonoscopy to make sure we can return their quality of life to normal. I mean, just because you've been on an expedition doesn't mean we have to ignore the basic medicine as well. If you're over 40 and you've had prolonged diarrhea resulting in weight loss and abdominal pain with that, now that weight loss more than 5%, you need a 2-week wait to know that there's not something sinister going on underneath that. So they're realistically the things I'm thinking about when it comes to duration of diarrhea. So the next part of my diarrhea sieve is if there's any blood in the stool. This is really useful in terms of narrowing down what's going on. If there's no blood in the stool, it's not dysentery. And straight away with that means that we can remove any of the dysentery causing issues such as entamoeba, E. coli 0157, Shigella, Campylobacter, any of those things can be taken off the table straight away. Now to clarify, when I'm saying blood in the stool, I mean literally bright red blood mixed in with the stool, not just a little bit on the paper when wiping, because depending on how often you're going to the toilet, it's not unusual to get some irritations around the back passage just because of that recurrent wiping. After having checked for blood, we want to know whether or not there's any fevers, and this can be again another really useful way of determining how ill your patient is. As soon as we can say that there's been no blood and no fever, that removes salmonella and cholera from our differential list as well. So we're really removing a lot of the big bads, as it were, from a traveller's diarrhea perspective. There are still lots of other causes of diarrhea once we've removed the bleeding and fever causes. However, the majority of those are less concerning and crucially they're self-limiting, so we can treat the patient symptomatically rather than necessarily having to address the diarrhea directly. Now that said, we need to keep in mind that just because a traveller has diarrhea doesn't mean that it is traveller's diarrhea. We need to keep in mind other features. So appendicitis is a possible cause of diarrhea that wouldn't necessarily have a fever and wouldn't necessarily have any bleeding. Hence, it's very important that we find out about any abdominal pain the patient is experiencing and whereabouts they're finding it. Hepatitis A, that can also present with diarrhea, vomiting, not necessarily a fever, but there we're specifically going to get the pain in the right upper quadrant over the liver. Conversely, with appendicitis, the pain classically would start around the umbilicus, around the belly button, and then move down towards the right side of the lower abdomen, the right iliac fossa. By comparison, a generalised abdominal pain doesn't tell us an awful lot in terms of clinically what's going on, but it does give us an idea of how the patient is suffering and what we might need to do for them. Just between you and me, one of the reasons why the camera keeps on changing and I keep looking down is because I'm in the jungle. I occasionally get stuff that decides to walk up my leg here. I'm not a big fan of it. Yeah, you should see some of the things we found last night when we came out of the room. With that in mind, the next thing we want to talk about is there any vomiting. Now, vomiting is actually a really helpful sign as it tends to be seen with viruses such as rota and norovirus. So we can be reassuring to the patient at that point that this is something that A, will resolve on its own, and B, the treatment is straightforward. We want to support them, make sure they're getting plenty of fluid and replace them with the electrolytes. And also how they describe it can be quite indicative. So norovirus is often described as projectile vomiting, and I think people are very clear when that's going on, rather than just, they're a bit unwell, they've vomited a couple of times. Now, when we've got patients with vomiting, a lot of people want treatment sooner rather than later, but in reality the antibiotics probably aren't going to be effective. So even when we're looking at Salmonella or Bacillus cereus, it's not actually the bacteria that's caused the problem, it's the toxin the bacteria has produced that's causing the vomiting, in which case essentially we have to wait for that to, for want of a better phrase, pass out of the body. Once that's done, things should settle on their own. So at this point I think it's worthwhile highlighting that Salmonella can cause vomiting, diarrhea and fever, so hopefully it's something that we would have addressed earlier on in our Sieve, and also highlighting that sometimes ciprofloxacin can be used to reduce the duration of that diarrhea, but only maybe by 12 hours or so. And frankly, we've got other medications that can do a similar job symptomatically without affecting the gut microbiome. So in terms of traveller's diarrhea, once we've done our assessments and we've done our diarrheal sieve, if we haven't found anything to refute our diagnosis, then we need to look at what's the best way to treat our severe or our mild traveller's diarrhea. For most cases, actually, we're looking at just symptomatic approaches, because traveller's diarrhea in mild form is going to be self-limiting. So there we're going to be talking about fluid rehydration, electrolyte replacement that's been lost in the stool, and also making sure that we potentially treat them with antidiarrheals so they're able to continue with whatever it is that they're doing when the traveller's diarrhea started. I can't underline that enough. Mild traveller's diarrhea is self-limiting, and it's very important for patients to understand that, because they're very much going to want antibiotics, they want the magic pill, they want things to resolve it straight away. Now, loperamide, antidiarrheals, can give them some of that benefit, but people often want the antibiotic because they think that's the answer to everything. So antibiotics should be used cautiously on an expedition, unless there's obvious indication, because they can do as much harm as they can good. And actually with mild traveller's diarrhea, they're probably not going to change things other than hours in terms of resolving symptoms sooner. And using antibiotics inappropriately can also take out the patient's gut microbiota, their good bacteria, if you will, which can put them at risk of other infections as well. So we could do more harm than good here. Now, with complicated diarrhea, so we've got the fever, we've got the bleeding, we've got the vomiting, antibiotics can have a more important approach. So if, for example, somebody's come down with Shigella, where a patient will report explosive diarrhea, here we'll use ciprofloxacin or trimethoprim. Campylobacter, which shockingly a large number of my friends experienced at university. Again, we get that bleeding, we've got the temperature, so we're going to want to look at antibiotics again, ciprofloxacin. And frankly, if the cause is unclear, we could be Shigella, we could be Campylobacter, I'd err on the side of caution and use those antibiotics. But there's always a but. Now, we can have mild traveller's diarrhea caused by straightforward E. coli. So you're going to get the same as you will do with Staphylococcus, Bacillus cereus and Clostridium. They're going to be self-limiting, as will the straightforward E. coli. However, E. coli 0157, that's quite nasty. Now, whereas straightforward E. coli will actually improve with a single dose of ciprofloxacin, E. coli 0157 is not, and actually antibiotics can increase the risk of significant complications, something called hemolytic uremic syndrome, where essentially the blood starts to clot and we get bruising to the skin, we get swelling to the legs because of clots affecting the kidneys. And that normally affects about 5% of individuals. However, that can increase to 10% if we give them antibiotics inappropriately. So I suppose one of the questions there is, how are you going to work that one out? Well, as mentioned earlier, E. coli 01507, the abdominal pain is severe. It's not just a little bit of cramping. That person's going to be in a lot of pain. So again, I'm going to take that opportunity to provide them antibiotics. As always, there are exceptions to the rule, and protozoa infections such as Giardia are a good example of this. They're often caused by infected water, and I've recently been in a hotel with signs over the bathroom specifically saying don't drink the water, and this is one of the reasons potentially why. And you really don't want to be on the wrong side of a protozoal infection. Whilst it's not serious in terms of medically worrying, it's majorly for the patient because it can be present for weeks. So if we suspect that a patient has Giardia, then we can treat them with up to 10 days of metronidazole. There are other medications available, such as Tindazole, but they, in my experience here, find that they're much more difficult to get hold of. Similarly, if that's not effective, we can try mebendazole, the same treatment we'd use for roundworms in children. That can also deal with the spores that can sit around in the intestinal wall that may not have been hit with the antibiotics. So now Giardia is, medically speaking, more of a problem for the patient, given the potential weeks of diarrhea, than it is a concern of something going wrong. But whilst it's great that 90% of cases will be treated by at least one of those three medications, the fact that it may take up to 10 days worth of treatment or a second line treatment after that does highlight how problematic it can be in terms of getting a resolution for the patient. And we see that in terms of how we can confirm that the treatment's been effective if need be. We need to have 3 stool samples taken multiple days apart to be able to say, yes, actually, the Giardia has been cleared. And if those 3 stool samples do come back negative, then again, we need to think, actually, has this brought forward an IBS, or perhaps more concerningly, an inflammatory bowel disease, where that parasitic infection of the bowel has stimulated the patient's own immune system to attack their own abdominal bowel wall. So at the bottom line, unless you're dealing with a complicated traveller's diarrhea, so bleeding, vomiting and fever, you're probably going to want to forego the antibiotics, probably. But make sure you assess each case on its own merits and make sure that you're pushing the supportive treatment no matter what else you're doing. So when it comes to those supportive measures, the most important part is making sure we're getting adequate fluid intake. And we want to be ensuring the patient's getting at least 100 millilitres of fluid every hour. And if we're in a situation where I'm actually concerned the patient's dehydrated, we've found sunken eyes, reduced skin turgor, we're concerned that they're the dryness of their mucous membranes, and there's not the ability to easily evacuate them out for further treatment, then we're going to very much push the fluids, and that can be getting that patient to take at least 1 litre every hour for 4 hours before we'll then review them again. over that time, and at any point where we're concerned about a patient's hydration status, we want to try and get them to record how much urine they're passing. So in terms of that, the average patient with this fluid replacement regime should be able to pass somewhere between 50 and 90 mils per hour. And if we don't have the ability to measure it, then a reasonable rule of thumb is that they should be able to pass clear urine at least 3 times in the day. As mentioned before, we're going to want to try and reduce down the actual diarrhea they're having, and we can do that with loperamide. But there's a loading dose required. So as a rule of thumb, you're going to take 2 tablets at the start of the diarrhea, and then you're going to take a subsequent tablet every time after you're having diarrhea, maybe for the first 24 hours, and see how things go then. Reviewing the patient and reviewing the management plan is a huge part of treating these travellers' diarrheas. But as with everything, prevention is going to be better than cure. So when you're away, it's about making sure you're eating safe foods and drinking safe water. That may be that you're drinking, bottled water, beers, wines and sodas only because you're in an area such as we have with the taps here, where they say very clearly, do not drink this water. It may be that you need to think about what foods it is that you're having. So avoid any what are called unpeelable fruits. So for example, star fruit is a fruit that you really just can't peel. Kiwis sometimes are unpeeled. In that case, make sure you're looking after yourself and thinking, could somebody have handled this beforehand? Could this food potentially be a risk to me? Something that often surprises people is when we advise them not to drink the ice. Yes, you may be able to say, I'm drinking Coca-Cola, other soft drinks are available, but I've got ice cubes in it. Well, hold on, you know where the Coke came from, you know that was from a sealed can. Where did the ice cubes come from? And we've seen that here as a possible source of the diarrhea, that there was ice cubes that perhaps weren't coming from a secured source, as it were. Well, I hope that's been a useful run over with travellers' diarrhea. I desperately hope that after all of this you can actually hear what I've been going on about in the wind, and yeah, I'll see if I can find the time to get another one of these in the bag. But yeah, until then, we'll see you later, and look after yourselves. Cheerio.